Hello and welcome for another episode of Profiles in American Funded Research. I'm excited today to have my guest, Harry Hochheiser. Harry did a BS, a bachelor's at MIT, a master's also at MIT. He got his PhD at the University of Maryland College Park, did a postdoc at the National Institute on Aging in Maryland and is now, now has multiple appointments at the University of Pittsburgh as a professor. And so obviously there was some stuff that happened in between, but I get everything right there?
Yeah, that's the short summary.
And I invited Harry on today because we're going to actually discuss some and I believe it's NIH funding, correct?
Exactly. Yep.
That's related to this Midas, which is the models of infectious disease agent study. And there's something called the National Institutes of General Medical Sciences that seems to be one of the pieces that's one of the departments that support Midas. Did I get everything correct there?
Yeah, so maybe I can just jump in and tell you a little bit about the context here.
I would love that.
So the first thing to say is, yes, we are funded by the NIH, and the NIH is divided up into a number of different institutes, which each handle different types of research. So just to give a couple of examples, there's the National Institute of Neurological Disorders and Stroke, NINDS. There's the National Cancer Institute, NCI. There's the National Human Genome Research Institute, NHGRI. We are funded by the National Institute of General Medical Sciences, NIGMS, which is sort of the all-purpose bucket where things that don't fit into any other groups go. It's also one of the largest institutes. I think it's second only in size to NCI, but don't quote me on that because I might have it slightly wrong, but it's up there. So Midas, the Models of Infectious Disease Agent Study, our grant is actually supporting the Midas Coordination Center. And there are a few things that I need to unpack to explain what that is, if that's okay.
Yeah, please go ahead.
So the first thing is to say, when we say Models of Infectious Disease Agent Study, well, this is sort of a cute acronym. I don't know how it came about. It's been in use for more than 20 years, but the general topic of research is people using mathematical models to predict the future of infectious disease outbreaks. So if we can think back to just about 5 years ago this month in early 2020, when COVID was hitting the scene, and you heard about flattening the curve, I think we can all remember that. The goal of this work of infectious disease modeling is to say, here's a potential outbreak or a potential flu season, for example. What is that curve going to look like? And there are numerous mathematical techniques, which we can talk about in a little bit more detail as you like, that can be used to develop these predictions. And so that's what we talk about when we say models of infectious disease agent study. And agent comes up because some of the techniques used are called agent-based methods. And I can say something about that later. Now, Midas as a concept has been around for about 20 years as a program for funding people to do this kind of work. In the latest instantiation, we have what's known as this coordination center, where we at the University of Pittsburgh and colleagues at several other institutions are funded to try to help the community of people doing this work. And we do this in a number of different ways, by curating data, by running educational activities, by doing a little bit of research on our own. But we're sort of a group that is trying to help bring some team science to that community of infectious disease modelers, help them with things that need help, and generally to be sort of a home for this kind of work in the research community.
And when you say team science, are you talking about people from a broad array of backgrounds? Is that?
Well, it could be a broad array of backgrounds. I mean, it's team science in a sense of trying to figure out how we can move this work beyond just sort of being one group of people doing their own work. How can we get the groups of collaborating, of people in the same field to collaborate, to work with each other, to learn from each other, and to build ways to make their models work better and more effectively, so to sort of leverage things. And I can talk about a couple of the team science initiatives that we have going on if you want to hear about that.
Yeah, let's jump right in and hear about the team science.
Okay, probably the biggest one that we support is not something that Midas started, but we sort of provide the technical support for this. It is something called the Scenario Modeling Hub. And this came out of COVID, and there are sort of two sets of observations here that led to, well, really one actually, but the first observation is to say that multiple models are better than one model. So if you're trying to solve a problem and you've got 10 different groups that are developing mathematical models to say, what is this thing going to look like in a little while? Each of those 10 groups might sometimes do well and sometimes do less well. But if you take the 10 groups all together and you develop what we call an ensemble model, which represents the consensus of all of those, you're probably going to do better than any one model would do at any time. And so it's a wisdom of the crowd sort of a thing.
That's sort of an approach that's taken with hurricane modeling as well, right? So
Exactly, right. And the strength of this lies in the fact that you get people doing different models using different approaches, different assumptions, and hopefully you come up with something with this ensemble that is a good guess. So that's the team science part of it, is that to make this work, you've got to get large groups of people together to make this happen. So the interesting thing that happened with the Scenario Modeling Hub was really towards the end of 2020, late in the first year of COVID. Some folks got together and decided to create this effort. They also decided to do something that was a little bit different than much of the modeling that gets done. A lot of times in infectious disease modeling, people are looking at a short term to say what's going to happen in the next month. And that's got some definite utility. But there's another set of questions which it doesn't answer, which is what might happen 6 months from now? And in particular, what might happen if the world changes in 6 months? So the Scenario Modeling Hub was formed by a group of people to get together to say, let's set up these challenges, these scenarios where we imagine what might happen in the next 6 months, and we see what the models look like. And so we might ask, for example, if there's a new variant in the next 6 months, or if there is a certain level of vaccination that happens in the next 6 months, or if there is immune escape, meaning that the bug finds its way around the vaccine and the vaccines become less effective over the next 6 months. Can we see what might happen there? And can we use that to inform decision making? Because again, what happens 4 weeks from now is useful, but you can't plan your vaccination strategy based on a short-term forecast, but you can on a long-term scenario. Now, of course, these scenarios are at best guesses, but we always fall back, at least I always fall back on that old cliche that, all models are wrong, but some are useful. The point is that by using these scenarios to get an idea of what might happen under some circumstances, we give decision makers something that might help them think about how to address those upcoming decisions that they have. So for example, when to roll out the next vaccine, who to give it to, or who not to. So since the fall of 2020, there have been 16 or 17 rounds of COVID projections done. We then branched out and added flu and RSV. Each have had a couple of sets of projections. And each of these things has had anywhere from 4 to I think about a dozen teams participating. And so we've been supporting this effort by doing all the technical work behind the scenes. So my team takes all these projections that the different groups make, runs the software to check to make sure that they're okay, the validation. We then run the ensembling code and put that together, and we support the websites that hold all this information so people can go and browse the data. And so we're sort of the behind the scenes players who are keeping the lights on, as it were. And to do this is the team science part that, we're not running it, but we're helping out, is we've got a coordinating team of about 13 people who meet weekly to figure out what to do. And then we have bigger meetings each week with all the folks who contribute. And, we've got to help sort of figure out how to get this large group of people to be working together towards this common end.
Now these models, because now you're talking about this ensemble approach, and these models obviously have different assumptions, as you mentioned, and things like that. But
Mhm.
I when I think of models, I think of them in I kind of place them in three categories. One that I call, say, the white box modeling, which is like from first principles, right? You develop some. It's like a physics model. You make a
Right.
bunch of assumptions and you develop some equations that should
Yeah.
model that all the way on through to a black box model, which is more like an artificial intelligence or machine learning type of approach where you might not you don't know what's going on under the hood. Essentially you just shove it through some
Mhm.
program and get this back. Are these models, are they one side or the other? Are they a mix of those?
I think it's all of the above in many ways. So there are people who essentially I should back up and say these are time series projection models, right? So um, there are people who use standard statistical techniques, which are really independent of infectious disease modeling, but they can be used to say, here's a time series, here's what we think it looks like, and here's what it might look like in the future. Just forgetting any other assumptions about what it's about or what causes it. So there are people who do that kind of modeling. I think that's a relatively small part of it. The other technique that gets used a lot are what we called compartmental models, which people may have heard of this during the height of the pandemic because it was discussed a lot. If you heard about R0, that really comes from this model of compartmental models. And this is a set of differential equations that says that people transition between states of being, say, susceptible to exposed to infected to recovered, and you can make those models much more complicated. But each of those transitions has some probabilities associated with it, and it becomes a very in its simplest form is a series of four simple differential equations. In its most complex form, you can add a lot of stochasticity to it and add many more compartments. But the idea being that you can run that at a population level and get a projection of what a curve might look like. The other commonly used technique is what's known as an agent-based model. An agent-based model, you build synthetic populations that could be even as fine-grained as saying, well, there are these people who are children who are going to school on these days, and these people who go to work, and you could use contact patterns to influence how many people each person is going to interact with in each day. And then you can assign probabilities in the same way that you would with a compartmental model of being infected if you're exposed, et cetera. And you can use that to just sort of turn a crank and say, each day, here's what happens. Each of these people do these things, they have these interactions, they spread the disease or not, and then it just continues on for the next day. So that is another form of the modeling that goes on. It's computationally extremely intense because if you think about modeling tens or hundreds of millions of people, it gets to be a big job. But it is used by some of the modelers a lot. Now there are also some folks who are throwing in um, deep learning models, and there are deep learning networks such as long short-term memory that are really good at generating predictions for time series, and so those might play a role. Those also have significant computational requirements, but then there are also people who are using machine learning and deep learning for just some small parts of this puzzle.
So now I kind of wanted to also discuss, switching gears a little bit off of the we'll probably swing back to it, but off of the modeling itself, and talk at least briefly about the stakeholders, right? So now you have to deal not only with, convincing, something that I'm used to in my community is I just have to convince the other people who are in my community that this is good work, and in order to get it published or whatever. But you have to go beyond just that, because you also have to convince policymakers, right? You have to convince hospitals, and you have to convince politicians and things like this, of the usefulness of what you're doing. So could you maybe briefly discuss that?
So this is an interesting thing, and the first thing I'll say is that this is a question that is really about the broader community more than the specific coordination center. So one of the things that is interesting is that people building these models really do want to have an impact on public health. They want to help and they want to work with public health folks. But as an NIH-funded project, we are mandated to be doing research with the Midas Coordination Center. So we don't stray very far into the world of talking with policymakers because that's sort of beyond our remit as the coordination center. But that said, everybody wants to do that. So with, for example, with the Scenario Modeling Hub, that group worked very closely with policymakers in the White House at the height of the pandemic to hand off the reports and the projections we made so they could use it. They also work with the ACIP, which is the CDC group that does immunization policy. And so it is a challenge to figure out how to present things well in reports that make sense to people and get the key findings across, because there's a lot of complexity and a lot of it involves questions that people aren't really cognitively great at. And by that, I mean, it's hard for us to deal with questions of uncertainty. And so if somebody says, well, what is the number of hospitalizations that's going to be on this given date? We're always going to have a large range with that because there's no way to say it exactly. As I said, all models are wrong. But conveying that to people who might want a clear answer is very tricky. And it is something that we try to think about. And there are some related projects that are outside of the scope of Midas that I'm working on that are struggling with this question.
Yeah, and even going beyond policymakers and stuff, the public at large, in order to get them to buy in and trust, that's also another caveat, I guess. But as you said,
it's very
you're mostly focused on the modeling side. So let's swing back to there. So can you explain some of the challenges that are associated with the modeling? Because I imagine, like, if you do go for a more first principles type approach, as an example, like the SEIR model that you were mentioning before, or something like that, you have to obviously then try to fit the parameters and things like that. And I'm just thinking about, in terms of data, the data's got to be a mess in some cases, right? So
yeah, absolutely. Getting good data is a real trick. One of the things that happened during the height of the pandemic, you might remember, is that the Johns Hopkins group, I forget what it's called, the CSSC, but they spent a lot of person hours collating and harmonizing data across many jurisdictions. And they were able to do this, I believe, largely through a very big grant from the Bloomberg Foundations. And that basically is a huge amount of effort, because what you saw was that you were getting data from all these different states, and they would be reporting in different ways. So they would not use the same file formats or the same metadata to describe their data. It would all be disjoint. And then you also have these problems with reporting, because the data is initially reported. It's never what the data really is. There are all these revisions. And so we would be on calls where they would be talking about the updates to the data, and they would say, well, this state had a big dump of deaths on this date because they did a death certificate review and readjusted the number of cases. That's always going to happen. And so you need to figure out then, what are you going to do with it? Because you can't leave that big spike in deaths on a given date in, because it's not that people died on that date, they were just reported on that date. So there are techniques both to sort of figure out how to handle that, or in the presence of these delays, to say, how do you model the reporting delays to figure out how to incorporate for them in the data? So those are all things that we take into account. And then you get to some other questions that came up. For example, when we were doing RSV, there, unlike with COVID or flu, there's no national reporting of RSV. RSV is a virus that affects infants mostly. It can be quite a challenge if they get them, but it's also something that we now have a vaccine for.
oh, so when we have to go 50 states then.
Well, no. Well, we did. I mean, often we do have to go 50 states anyway, right? As I was saying, but it would. But when we try to use things like the CDC data, they don't collect data for this nationally. It's not mandated for all the states. So there's data from, I think, about 13 states on RSV, and so you have to figure out, well, how do we build a national projection when we don't have local data? And some of that is just scaling and extrapolating when that's the best you can do. But knowing what the data is and what it means and what it doesn't mean is very tough. And so last summer, for example, there was some of the reporting was shut down over the summer. I believe that was for flu. It may have been COVID. Don't apologies if I get that one wrong, but there was a gap. And we're looking at that again this year, and we're sort of saying, well, can we look at what states are reporting individually instead of having federal reports that aggregate everything? And we're trying to support that as best we can. And so again, the same person on my team who's doing a lot of the support work for the Scenario Modeling Hub has been assembling a bunch of data sources that can be used to make the projections.
So when you mentioned a bit earlier about the validation of the models, and how do you go about that kind of validation? Because all of these you already have challenges with even collecting data and things that are involved. So it seems like a pretty complicated thing to then validate the models against noisy data and things like this.
Yeah, I mean, I think that's a real trick. Now, it's easier with the short-term forecasts, right? Because if you say, for example, on March 1st, you're going to predict what the flu season is going to look like. It's a bad example for March 1st because the flu season is mostly over by then. But if you want to predict what the flu season is going to look like for the next 4 weeks, you can run a model and get your prediction. And then on April 1st, you could go and get the data as available, and you can say how well did you do based on what actually happened. And so that's how you would evaluate a short-term forecast. With the scenarios, it's actually much, much harder because the scenario that you define may have been your best guess as to what happened, but that may not have happened that way. So there was a big effort that was undertaken in 2023 to evaluate all the work that had been done up to that point on the Scenario Modeling Hub. And what they sort of did was to say, okay, let's look at those times and find out when the scenarios were reasonably representative of what actually happened, and to restrict the evaluation to only those weeks and to leave out the rest of them that it wasn't even close. And then they evaluate to say, well, how well does the ensemble do relative to a simpler model, so that you could say, okay, well, what actually happened may not be the best comparator either, but the simpler model is something that we find useful. And so they have a variety of measures that can be used to evaluate that. And even there, the question of what to evaluate and how is complex and gets pretty technical pretty quickly because there are a number of different metrics that can be used.
And now you mentioned that you have cases where in some like RSV, you only have a few states reporting, and you have other cases like COVID and the flu, right? The flu where everybody sees. So you have good data in some cases and bad data. Well, bad coverage, I should say.
Less complete.
Yes, less complete data in other cases. But I imagine that there is some kind of interrelation between these diseases, right? So like maybe if you have a bad RSV year, that might actually affect how much COVID you have. So how do you kind of then map those things to each other too?
That gets very tricky very quickly. Most of the work that I'm aware of does one of two things. One is that it just sort of looks at infectious diseases as a whole and doesn't try to differentiate between them. The other one is that people will sort of take fairly simplistic assumptions about the relationship and use those. I'm not aware of too much work that gets into really deeply getting into questions of modeling the likelihood of how the likelihood of say having flu, how that changes your likelihood of getting COVID or not. And one of the reasons for that is that's very, very hard to get at that. Because if you think about, say, reporting for flu, it's going to be hard because many people are going to get flu and they're not going to go to the doctor. They're not going to report it. They'll have a couple of miserable days at home and they'll go back to their lives. So getting the counts is really, really tough. And it's going to be the same thing with COVID. As COVID now becomes just something in the background, the reporting numbers are not going to be great because people aren't going to go to the doctor for it. So how do you know that somebody had flu? How do you know that they got COVID? And how do you know that those are related? That's going to be really very tough. And if you did in-depth contact tracing, you might be able to get somewhere with that, but that's really expensive, difficult to do. So I think that's likely to be an intrinsically hard problem. Now, I will say that I'm aware of some efforts. We had one here at the University of Pittsburgh that I was involved in where people were looking, we were looking at a local scale at hospital reports and emergency department reports. And we're using that to build Bayesian models that would predict or classify people as being likely cases of, say, flu versus RSV versus COVID. And if you had that kind of data, you might be able to get some notion of people coming in and which diseases they have. But to say how that impacts the likelihood of somebody, how somebody's flu impacts the likelihood of they're getting COVID, I think is still going to be a very, very hard problem to get a handle on.
Yeah. Now, since you, I'm gonna have you back up for a minute there because I am trying to sort of target a general audience. So
Sure, go ahead.
can you just explain to the audience, say, the difference between the frequentist approach and histogram approach and Bayesian type statistics? Because I don't know that the average person knows the.
No, and I guess, and I'm not a statistician and I'm not a modeler by training. So, the Bayesian way of putting it is basically this idea of saying that you have some prior information about something and that changes your likelihood about what's going to happen, your guess as to what's likely to happen. And so a Bayesian model is going to say, given all of these factors, like, oh, somebody's got a cough and somebody's got a fever, that influences the likelihood that I think that they've got flu. And if I add in some other symptom, that might make it more likely that they've got COVID. So we're starting up with a bunch of prior odds and then looking at these symptoms that somebody has and using that to determine which disease they think they most likely have. So it's all about this question of going from your initial belief not having any information to your final belief, which we call a posterior, which is adjusted for what you've learned about a situation. And that's at the basis of a lot of these approaches. And by the way, I should say approaches like that can also be used to do things like filling in the holes in the data sources by making Bayesian estimates of what those values might actually be.
Right, because yeah, not only you actually the health data seems to be a real challenge because, as you mentioned, there's just so many things, people not reporting because they don't get sick enough to bother going to the doctor or whatnot, but also the fact that there's a delay in reporting sometimes from the states themselves, and then you might have missing data. So you have the traditional problems as well as on top of these other nuances that that don't necessarily exist in other places. So I can understand it's a real challenge.
Mm-hmm.
Now, I noticed when I was looking at some of the work that you do, and maybe it's not related specifically to this, but maybe you could still discuss it anyways. That you have some work on natural language processing, which actually surprised me. And so maybe because I wasn't sure how that might apply in a scenario like this, and maybe the answer is it doesn't. But maybe could you discuss that?
Sure. And the first thing I'll say is, I, again, as I said, I'm not a modeler by training. I'm not an epidemiologist. I'm a computer scientist by training, and I work in the Department of Biomedical Informatics, which basically means we do a lot with just about any kind of medical data we can get our hands on, or even in some cases biodata. So what we find is we end up using a bunch of different techniques. So the project you're thinking of is probably the work I do in cancer informatics, where we're building models for extracting information about cancer patients and trying to use that to build longitudinal models of what happens with a cancer patient in terms of what drugs they get, what symptoms they have, and to understand that at a high level over long periods of time. I actually don't do too much of the NLP in that project myself. I have a collaborator who does a lot of that, but we definitely build models to try to pull out these pieces from the notes. And I'll just give you an example of one of the hard challenges there, which is that if you're a cancer patient and you see 5 doctors in 3 days because you're going through early diagnosis, you're going to get all these notes that talk about the tumor. So if I've got a dozen different notes that talk about a tumor, I want to be able to tell that it's the same tumor in each of these documents and not a different tumor. And so that ends up being an interesting problem of what's that we call that cross-document co-reference resolution. And so I don't want to say too much more about the details because, again, that's not my work, it's my collaborators' work, but I've been helping them with the other side of it, which is to try to figure out how to take all the information that you get out of these things and then to build longitudinal visualization tools so you can sort of see a patient's history over time.
Okay, yes, it makes sense that it's not necessarily related to, because you have many projects. I will note you have your hands in a lot of different things, but
I could say something else, by the way. That project that I mentioned with the Bayesian models of symptoms is that's also based, again, not work that I've done, but it's based in natural language processing, because what they do is to take emergency department reports and to try to pull out all the symptoms which may or may not be noted in a structured data that you collect in an electronic medical record. But they want to get things like fever or cough, or also the fact that somebody denies a cough, they don't have a cough, and that's a signal too. And so those observations extracted from the electronic medical record become the data that go into building that Bayesian model.
so it actually seems like this could end up being related to this project as well at some point, or because I imagine,
Mhm.
like, if you were trying to catch a disease that's coming up right now, right? Like when COVID was first starting or something like that, having knowledge of what common symptoms are would be something that would be sort of important. So I could see like a natural language processing element there too.
Yeah, yeah. And actually, in this project, one of the things I didn't mention before is they build these probabilistic models of which disease they think it is. But at the same time, you can also say, not only, hey, I'm modeling each of these diseases, but you can look at that and say, given these models for each of these diseases, under certain circumstances, you might say something that gives you a hint of saying, oh, it's none of these diseases. It might actually be something new that's showing up. And they've used this, at least on retrospective data, to identify an outbreak of something that hadn't really been observed. And this is, in some sense, what we'd love to be able to do, would be to have something that looks at patient data as it's going through and builds dynamic models that might give us some hint about some new bug earlier, perhaps before we even realize that it's floating around, and then that we can say, okay, now we can intervene and really be ready to respond to it.
Yeah, that's really fascinating. And that I think could then also be potentially paired with some of your ensemble forecasts that you were discussing before. So you could kind of even map out potentially what's going to happen, 3 months from now or something like that.
Yeah, absolutely. And this becomes useful information to particularly for institutions to say, and when do we need more hospital beds? When do we need more staff? When do we need to get more supplies or order more vaccines? And that's the goal, is to really to have something that is useful for public health.
Now, for this Midas project, how big is the group that you're working with? So maybe you could discuss both your own internal group and then the broader group that's working on this here.
So I don't have an exact count. We've got about half a dozen people who are working full or part-time here at the University of Pittsburgh, but then we've also got collaborators at several other institutions who are doing parts of this, particularly on the research side. And I can talk a little bit about what they do if you want. But then the Midas community that we support, we have something like 1,200 people who have identified themselves as Midas members who get our weekly mailing updates, and they're on the website, and they can participate in our events. And so we regularly have webinars, we do an annual meeting, and so we try to be responsive and available to that larger group.
Now, could you go through, you mentioned the research. Could you discuss that part of this that you said you could go into a little more detail? I'd love to.
Yeah, absolutely. So there are a couple of things that we're working on here at the center. And basically what we are going to do here is we're looking at the field of infectious disease modeling, and we're trying to figure out how is a field, where are the gaps, and where could things be done better. And so one of the things that I'm interested in, that we've been working on for a while, is to support reproducibility and to help people make things more of a science. And to do that, we're really talking about data and metadata standards. So what do I mean by that? Well, we already talked about how some of the source data that people use to build these models is very hard to work with because it doesn't use common formats and isn't necessarily described in the best ways. So we've been thinking about, can we build descriptors so that we could say, here's a set of data and here's what it looks like and what is in it, and keep that in a common format so that people would be able to compare data sets more easily and more readily to know that they were available. And then to make those data easily compliant with what is really the standard practice in the field that people aim for, is what's known as FAIR: findable, accessible, interoperable, and reproducible. So we're trying to figure out better ways to describe data so that we can make it more useful for people. We're also thinking about better ways to describe models. How can we get something like a computer readable file that would be a description of a model so that we could begin to compare models to each other more effectively? Because if we can do that, we can do the science better, and we can begin to ask questions like, hey, I've got this new variant way of doing a model. I want to compare it to what went beforehand. And so I want to tell you what I did, and you can see how it's different from what went beforehand. And so you can interpret our results appropriately. And we can begin to ask these questions in more fine-grained detail and begin to build the science part of it to say what works well and doesn't, and when. So that's one thing we're working on. Another question is, getting to this ensemble question. One of the things that happens when these groups put together their projections is, because there's stochasticity in each model, they run model many, many times to get an idea of what their output looks like. Well, this raises the question of how many models is enough. And because the models are complex and generate in different ways, there's no easy analytical solution to that. We can't just model it and say, oh, it's a Gaussian, where here everything falls within, this is 2 standard deviations, and we're done. So what we're doing right now is we're trying to develop models for empirically saying, well, if I'm generating some number of projections, how can I tell when I should stop? By basically measuring the marginal return on each next additional model that you run, and saying, once that marginal return falls below a certain point, then we could say, okay, we're done. We don't need to go any further. We're not adding new information. So we're looking at that. Another thing that we're trying to do is to figure out, and this really is a complement to the metadata kind of thing I was saying, is if we want to extract information about a model from a paper, for example, we're exploring the possibility of using large language models to say, how can we extract the impertinent details from a paper about a modeling effort and get those into structured form to describe what's going on. So these are a couple of things we're working on, but we're also doing a couple of things that are slightly more mundane, like building up benchmark models. So again, a common framework that people could run their models against to use that as a way to evaluate things. So these are a few of the things that we've got going on in the group.
All right. Thank you for that. And I uh, am trying to, as I noted before, keep these to a certain time frame. So I don't want to take up too much more time before getting on to the next.
I'm good to continue if you want. It's up to
Yeah,
you, really.
before getting on to this next topic, which is, of course, how are the funds being spent? And I know that in this case, it seems to be because it's an institute, or Midas is like an institution in and of itself. That's a little hairier to kind of track down all of the details. But what is the money going for in these cases?
Yeah. So I did review our budget to take a look at that question. And basically, it's about 75 or 80% personnel. And it's this is bigger than any single research grant. So it's a fair amount of personnel, but it's still mostly personnel. And most of that is research staff and faculty. We have a few students, but not so many students, mostly because a lot of what we do is operational, ongoing kinds of things rather than the research things. Although I must admit, some of it with the subcontracts of the collaborators, I don't know exactly how they've got all that laid out. A couple of other things that we do spend money on that are substantial is we have an annual meeting every year that we fund all of the costs of putting it on, so that people can come, and as long as they can get themselves there and have a place to stay, we take care of the facilities and the hotel, meeting rooms, and all of that. And that's not inexpensive. But we get 130 to 150 people a year who come to the meeting, and that's a good way to exchange information. One of the things that's nice about that is we always get a lot of trainees, students, and postdocs to show up. So that's a chunk of money. We also have a bunch of money that we put in for various small pots of community support efforts. Like we support people going to some training programs, and we support a conference to get undergraduates interested in modeling. We also have a little bit of money that we're making available to anybody in the community who might want to propose a small project, things like that. The other big chunk that I haven't mentioned is that, as I said, we have all this support for, say, the scenario modeling hub and a couple of other things we do. Like we have a big data catalog that we maintain. All of this stuff is on cloud services that we have to pay for. So that's not a huge chunk of money, but it's one of the bigger single line items aside from the personnel.
So I'm obviously well aware of the fact that currently there's a little bit of uncertainty at the NIH, and is that affecting you at all?
With this program, not yet. We have not heard any concerns, and I'm hoping that we don't. That said, we're in unfamiliar times, and so there's just a lot of uncertainty in general. And right now we are in the process of doing something that every NIH grant does every year, which is writing the annual report, which is called the RPPR. And the way it works is that upon receipt of that report, one of the things you do is you write a budget for your next year, and then they release the funds. And so we're just crossing our fingers to hope that will go smoothly.
All right, and I don't know if you've seen some prior episodes or not, but one question that I really love to ask, because out of personal interest, is how did you get started in science? What got you interested? If you could go back maybe to high school or earlier, maybe what got you on this path?
So you might have seen that all my degrees are in computer science, and what happened was I grew up in the age of the early days of microcomputers. And when I was in middle school or junior high, actually, there was a math teacher who had an early TRS-80 Radio Shack microcomputer that was in the classroom that we could use over lunchtime. And I started programming in BASIC, and I learned that, and I thought that was fascinating. And So I went and studied it as an undergrad, and bunch of twists and turns there that I won't bother to get into, but I ended up going to graduate school for computer science and just sort of ran with it from there. But I just got inspired by playing with the computers and making them do things. And I unfortunately don't get to do that nearly as much as I used to, because being a professor in the end is a lot of writing and management more than it is actually doing research, as you know. But I still enjoy that when I can.
You dated yourself when you said basic, but uh the
I dated myself when I said TRS 80
yeah,
for
that's
anybody who wants
true.
to look that up.
But so uh it seems like, yeah, I did notice actually that your degrees were in computer science, and now you also have this this element of disease, right? Of modeling disease and such. And so was that started in your postdoc or earlier than your postdoc? Because I noticed your postdoc did have that element, but
Yeah. So in my graduate work, I did little bit of work in bioinformatics. And then in my postdoc, I was working in a computational biology lab that was really more looking at basic biology and microscopy than about disease per se. Um, and now I do a lot of work with healthcare data. And the story is too long to go into.
that's fair.
But I mean, this is not for the podcast, but just so you I think might find this interesting, that basically, what I tell people about my career is I've gotten very lucky over the years. I was teaching in a computer science department in a state school in Maryland, and my wife, who's a molecular biologist, was looking for a position because she had sort of run out the clock on a postdoc, and then she had a career development position, but it was time for her to really become a faculty person. And so she started doing the job search, and we had a classic two-body problem. And her CV ended up on with somebody in Pittsburgh at the McGee Women's Research Institute who really wanted to hire her. And so she said, "You got to find my husband a job." So I sent him my CV, and it bounced around, and it landed in the desk of the chair of the Department of Biomedical Informatics. And I had no idea what that meant at the time. But the chair saw something he liked and invited me in for a talk. And he sat me down after I gave the talk, and he said, "I want you here." And he said, "I don't believe in consolation prizes or things like that. I want you here because I want you here." And so that was 15 years ago, and I've just made a run of it. And I'll say, I'm also now the director of our graduate program, which I've been doing for the past 7 years or so. And I always tell my students, it's great to have a plan for what you want to do and a vision, because it's good to communicate that to people, but it's also really important to be willing to see opportunity when it comes your way, and even if it takes you someplace you never thought you were going to go. And so that's what I've done. And I feel very lucky and fortunate that it's worked out that well for me.
I appreciate that story. That's awesome. Well, that's all that I had for this, and I wanted to thank you so much for joining me, because this is wonderful to just keep getting a broad array of people on and that are willing to come on.
Well, I want to thank you, because I think what you're doing is really great, and I hope people hear it, because it's the kind of outreach we need, which is why I got in touch, because I thought, yeah, we got to do more of this and tell the story well. So I hope you're getting some traction and listens.